Good evening and welcome everyone to tonight's Nordocs webinar, Myth or Fact, ADHD in Adults. My name is Dr Peter Silberberg. I'm a GP at Lennox Head Medical Centre and the Aboriginal Medical Service Rekindling the Spirit in Lismore, and I'll be your presenter for tonight's webinar. Start with acknowledgement of country. I'd like to acknowledge the traditional owners of the land on which we meet today, the Bundjalung Nation, and pay my respects to elders past and present and emerging, and to any Aboriginal people who may be attending tonight's event. The Bundjalung Nation extends from Grafton on the Clarence River in the south to the Logan River in the north and inland as far as the Great Dividing Range at Tenterfield. Just a reminder that Nordocs is a network of all doctors, including GPs, specialists, doctors in training, including medical students, living or working in our geographical footprint. One of our aims is to support all its members by improving the health of our community. And education is a big part of this process, including these webinars, our flagship quarterly magazine, and hopefully one day a return to face-to-face education. I'd like to thank our sponsors for tonight's event, the Currumbin Clinic. Nordocs is a not-for-profit organisation and relies on sponsorship to run these education activities for its members. So, to our guests tonight, I'd very much like to warmly welcome Dr Hugh Morgan and Dr James Whan, and we'll get them to turn on their videos. Good evening, James.
G'day, Pete.
And just make sure Hugh's on my screen. There he is. G'day, Hugh.
Hi, Pete.
So thanks for coming along tonight. So you guys are both new to our area, and perhaps not many people have had a chance to meet you yet or speak to you on the phone. So Hugh, I might start with you. Just briefly tell us a little bit about your journey to coming to live on the North Coast.
I had been working in Sydney in a practice that my wife and I created called Mind Care Centre in Broadway. And really, I guess a combination of things. Our children are now in their early 20s, and we had some friends who bought some land in Kurrabell, and we went and visited them and looked at the land, and there was a block next door to their block, and we bought it. And it was subsequently, particularly with COVID, that we realised that we could actually move and leave Sydney and come here. And we did that in February this year, and it's been a great decision. So now I'm working at the Mullumbimby Comprehensive Health Centre, and Heidi and I are nestled there, and our practice is still there, and we've got our own reception area, and I'm there 3 days a week. And I have started working at Rekindling the Spirit as well, one morning a fortnight, and that's been a fantastic thing for me to do as well. And I'm really enjoying learning more about Indigenous people and their health needs. I've had an interest in ADHD for probably about 15 years now, and it started for me after a child adolescent psychiatrist has abruptly left his practice and actually moved to Queensland. And I inherited something like 20 young adolescents, people in their early 20s, and I didn't really know anything about ADHD. And so it's really since that time that I've kind of learned a lot. And probably over the last 10 years, 50% of new patients who come to see me are presenting because they feel they have ADHD, and most of the time they do. And I've been continuing to learn and to really enjoy assessing and working and treating people with ADHD.
Oh, that's great, Hugh. It's great to have you along tonight. And just so people know, your scope of practice, apart from ADHD, generally your scope is all general psychiatry?
That's right. I'm a member of the section of youth psychiatry in the college. And so I've always had an interest really in sort of particularly the period between 15 to 25. And this is, time when people are most vulnerable and at risk of developing mental health disorders. I would see myself really as a general adult psychiatrist with an interest in youth psychiatry. And, I'm experienced in treating mood disorders and anxiety disorders. And I have certainly seen, a reasonable number of people with pain disorders and also fatigue syndromes. I've seen quite a few people, courtesy of Professor Ian Hickey and Professor Andrew Lloyd, who's a professor of infectious diseases at Prince of Wales over quite a long period of time as well.
Fantastic. Thank you so much. And James, what about yourself? What brought you up to the North Coast?
Look, I'm from Melbourne. I was sick of the city, the traffic, and everything that goes along with that. I'd been locuming for about 12 months prior to coming up here, checking out basically a spot to live. We were about to have our first child. And look, you come to the Northern Rivers and it's the most beautiful part of Australia, I think. The scenery is obviously amazing. The people are really generous, welcoming. And there's a real focus on living a sort of a balanced life with work and creativity, if you like. I've sort of moved here 4 years ago. I've got my 3-year-old boy now, a wife, work 3 days a week, and I've never been happier. I just love it here. I sort of feel very much part of the community. And with that, I think there's a bit more added responsibility of feeling you've got to actually do a good job because you might see the people around, or at least you know them by the community at least.
That's great.
So,
and your scope of practice as well?
So I generally see the 3 main things I see are ADHD, and that's probably about half my practice. I see a lot of work cover, first responders particularly. It was only since moving up here I realised how tough police have it, and I see a lot of police. And also DVA. I think there's a lot of DVA and police up here that need assistance essentially. So they're the 3 main ones. I'm a general adult psychiatrist. They're the things I sort of specialise in.
That's great. Oh, that's fantastic. Well, it's great to have you guys on board for tonight. So let's move on to what we hope to get out of this evening, which will be learning outcomes. And just before we go there, just a reminder that if you want to ask a question during the event tonight, if you just go down to the bottom of your screen, remind yourself there's a little chat thing there that says chat box. Just click on that and write a question in the window, and we'll endeavour to get to your question during the webinar, and there'll be time for questions at the very end as well. So at the end of tonight, we very much hope that you'll feel more up to date about general facts concerning ADHD in adults, a better understanding of how to recognise ADHD in adults when they're sitting in your consultation room, and understand how the condition is diagnosed, and then very much hope that at the end you'll feel much more confident to be a co-prescriber of stimulant medication with a psychiatrist. And just a brief thing too, at the conclusion of tonight, we're going to have a mystery guest, so hang around for that, an old friend of Nordoc's, who'll be talking about a newly released podcast. So that's at the end. But for now, let's get back to ADHD. So the next slides, we're going to have, we thought we'd do a bit of a myth or fact kind of presentation for this evening. So these are general myth-busting facts about ADHD. So we're going to start with Hugh. So Hugh, myth or fact, ADHD in adults is a separate entity to ADHD in childhood?
So this is a bit of a myth, really. And there's been quite a lot of research and interest in whether, in fact, ADHD is separate. And here we are explaining that ADHD is very much a family affair, and that clinicians are often asked, like me, to kind of examine the parents of children who have been diagnosed with ADHD. I think one way of thinking about ADHD is that 95% of adults do not have ADHD. So I think that's a kind of helpful thing to think of that. However, what is interesting to consider is what number of people in your waiting room may have ADHD. And that's probably going to be more because ADHD has lots of comorbidity. And the other thing is that ADHD is probably going to continue into adulthood for at least 2/3. It's probably more likely to be upwards to more towards 80%, in fact. And so this is why the percentage of children that have ADHD is higher compared to adults. Boys tend to present more in childhood compared to girls, but in adulthood, the frequency is fairly similar for men and women having ADHD.
So what's the background rate of ADHD in adults approximately?
So in terms of, if you look at the percentage, so it's roughly 4 to 5% of adults may have ADHD. And of course, this is a neurodevelopmental disorder, so it's on a spectrum. So some of those people may have mild symptoms that don't necessarily warrant treatment. Other people may have, moderate symptoms. Of course, they're the people who are going to really present and see us and have problems. And some people have really severe ADHD. And the thing that makes this tough is that it often comes with depression and anxiety compounding their problems.
Yeah, so that's really interesting to know, and it's quite a high number really. When I first heard you tell me that, thinking from memory, I think background rates of bipolar schizophrenia are about 1%. Correct me if I'm wrong. So 4 to 5% is a high number, but yeah. So and it's a spectrum, is what you're saying there. So we might recognise the severe end, but there's going to be everything from mild to moderate in between. Yeah. So we'll move on to the next myth or fact. So James, this one's over to you. Myth or fact, all psychiatrists believe in ADHD?
I think 15 years ago, this would have been a hard no, or myth, I think. Is that, myth. Certainly, there was no training in adult psychiatry for adult ADHD. We didn't learn about it at all. And I would have been one of the people that didn't believe in adult ADHD. I think over the last decade, particularly, there's been a lot of advocacy with regards to adult ADHD and a lot of psychoeducation within the college and destigmatisation. So, I think now, at least in my eyes, at least 50% of psychiatrists, adult psychiatrists, would believe in adult ADHD. Where I work in Bangalow here, but also up in Crumlin Clinic with sort of about 10 or 12 psychiatrists. Most of the psychiatrists up there treat adult ADHD and they do it quite confidently. So I guess from my point of view, and I'd be interested to hear what the GPs sort of felt, I do believe that now most psychiatrists believe in adult ADHD, not all, but most.
Is it when you were going through, I'm interested to know, when you were going through training, was it part of the core teaching?
Not in child psychiatry. We did like a 6-month child psych there. I'm from Melbourne, and Melbourne's very sort of la-di-da, where it's psychodynamic sort of training and medication sort of looked down on. Even in child psychiatry, stimulants were sort of looked down upon as very much the last sort of gasp, if you like, and it was all about sort of managing the system, the parents, and adult ADHD wasn't at all talked about. And even more recently, I think, it has become more part of the syllabus, I think.
Oh, that's really good to know. So so we'll go to the next slide there. So if everyone could take stimulants, we could all benefit. Hugh.
Well, this is an interesting one, and there's a bit of myth and fact in this. So I love my coffee, but I don't have ADHD, and it certainly does help me. And there's good evidence that it does improve focus, concentration, and alertness. If you look at the response that people have who have ADHD to stimulant medication, it's an enormous effect. That is, if you look at effect size, the effect size is large. So it's about 0.8 to 1. So treatment for those people with ADHD with stimulants is amazing and quite dramatic. If you're one of those people, the 95% of adults who do not have ADHD, and you take stimulant medication, it might, improve focus, concentration a little bit, but not much, and certainly not nearly as much as somebody with ADHD. It's also possible that you might actually feel agitated, anxious, and it may actually impair your ability to focus and concentrate. So it is interesting. So certainly people with ADHD have significant benefit from treatment compared to people who do not have ADHD.
And does everyone with ADHD benefit from stimulant medication?
So roughly 90% of people who have ADHD will benefit substantially from treatment with either dexamphetamine-based medication. So there's dexamphetamine or Vyvanse, which is long-acting dexamphetamine, or methylphenidate. It's roughly 50-50. So sometimes somebody will try dexamphetamine, and they may find that it makes them agitated, anxious, or heart races. Then they try methylphenidate and it works very effectively and they feel good. 10% of people just cannot tolerate stimulants. Another group of people may have significant substance use problems, and those people may benefit from a non-stimulant. So atomoxetine, which is a noradrenaline reuptake inhibitor, can be used. Guanfacine, which is an old antihypertensive, and another off-label antidepressant that can be used is bupropion. A third-line medication can be modafinil. So there certainly are a number of options that can be used instead of stimulant medication.
And someone is asking, how do you define benefit? Like, is it, are you using rating scores, or is it on patient feedback, or?
So it's a bit of both. And I guess my wife is a clinical psychologist, and so I've been imbued with using rating scales, questionnaires, outcome measures. So what I find typically is using the ASRS, which is an adult ADHD rating scale, that people tend to improve. The symptom scores drop by at least 50%. So it's quite dramatic. Sometimes people don't. So that's useful, kind of using the questionnaire again. But generally, the person self-report, a spouse report, it's quite interesting. They will. That's the nice thing about it. When people respond well, they generally get quite a dramatic response, this large effect size. It's quite, I still find it quite remarkable, really, that you can take a tablet and get this incredible response. So it's a very gratifying disorder to treat, and people, generally feel very grateful. It doesn't always happen. Sometimes, things are complicated, and it doesn't always go that way, but it certainly does, probably for 70 to 80% of the time.
Yeah, and I know that I'm talking to my patients who have been diagnosed and started stimulant medication and get the same story. So thank you. So James, the next one's for you. So patients who are seeking a diagnosis of ADHD are mainly drug seeking. Myth or fact?
I think it's a myth. I think rarely patients come to me anyway, drug seeking. Almost always they're seeking help. They realise that their life's harder than other people's. A family member or a friend has been diagnosed with ADHD, or a GP or a psychologist have asked them to be assessed or suggested they get assessed. They'll look up online and they'll really resonate with the symptoms. Occasionally you get people with substance use disorders that seek help also and come to you. You might get someone who takes ice and says, look, ice makes me feel normal. It calms me down. I know it shouldn't do that, but it does. And they realise that they're self-medicating. And these people can be good to treat too. You've obviously got to get them off the ice, and you're probably not going to use stimulants. You use atomoxetine or another agent first line. But yeah, look, very rarely do people come to you drug seeking. When they do, they generally reveal themselves quite quickly as well. They'll either sort of lose their scripts over and over again, or they'll sort of rock up to the consultation sort of wired, not this sort of calm effect that stimulants have on people with ADHD. And look, if people sort of do pull the wool over my eyes, a couple of times a year, I'm okay with that. Like, I think under treatment is a much bigger problem than over treatment.
Yeah. So, and we're going to get to that. So, I think that's a really important question, and so many, I don't know what percentage, I haven't read the trials, but I know from my population of people with ADHD, quite a few of them for various reasons have dabbled in street amphetamines, or they've borrowed it from a friend. Occasionally you might have an adult, stealing a child tablet, and but there are a number of people who have been using it illegally who want help legally because they've recognised it's made a big difference to their life. So I think that's, in my experience, that's more commonly the story too. So we'll just go to the next slide for you. So Hugh, just quickly, there was another question before about benefit, and do you know, someone was asking whether in the trials, if there was any benefit from placebo in the trials. I don't know if you know off the top of your head that answer.
Look, I don't know from the top of my head, but I think that in most trials there's a placebo effect. I think the nice thing about this is that the effect is sustained. So usually a placebo is not going to be sustained. And I guess the nice thing about stimulant treatment is that it's been used now for 30, 40 years. So it's interesting. ADHD is probably one of the best researched disorders in psychiatry, probably out of all of the conditions. And so I think it's pretty conclusive that the response to treatment is real and not due to placebo.
Yep. And
can I just add something there?
Oh yeah, of course. Yeah.
Like ECT and stimulants are probably the best treatments in psychiatry. They're the only ones that make amazing responses, or this wow effect you get. So
there you go. That sounds like another webinar on ECT coming up. So ADHD is a serious psychiatric condition and is underdiagnosed. That one's to you, Hugh.
So that is very true. It's interesting. I think James was saying that it's now more accepted amongst psychiatrists, but unfortunately that may be true. But I think a lot of psychiatrists really feel a bit unsure about treatment and how to treat. And this was a recent review done. It was in 2019 by Deloitte, and it's just showing over 800,000 Australians are estimated to be affected by ADHD. This is in 2019. And basically the majority of those Australians are untreated. In another survey, this was with the Department of Health, the ADHD was the most common mental disorder in children and adolescents. That was in 2015. So it's very, very common. The cost of untreated ADHD is enormous. The other thing that's really interesting, there's been quite a lot of research looking at mortality of people with ADHD, and this research done in Denmark looked at something like 2 million Danes, and out of that 36,000 people had ADHD. The mortality rate, removing all other confounding factors, was about 2.6 times greater than those who did not have ADHD. This is people who are not treated. And it's pretty due to accidents. So people are more impulsive, they have car accidents, they go bungee jumping, they take risks. So it's an amazing thing. So that's looking just at mortality. Suicide rate is also higher, which is interesting. And there's really quite nice data showing that the risk of having a car accident is increased by nearly 50% if people do not take their medication. So that's one of the things that I tell all my patients: please make sure that you take stimulant medication when you're driving at all times, just like wearing glasses. That's how I would see it.
Wow. I'm surprised it's not on the RMS driving form. It's interesting it's not on there, is it? Yeah. Okay, that's an interesting statistic. So we'll go to the next slide. So, James, if your patient is a high-functioning individual, perhaps even a doctor, you should still consider ADHD.
Yeah, very much so. You can, high-functioning people can and do have ADHD. It's not typical. Typically, people's lives are more chaotic and they probably don't function up to their optimal level. But you can and do, and high-functioning people can and do have ADHD though. And they sort of compensate in different ways. You can sort of, if you like, have more effort. So if you're studying for an exam, for instance, you can set aside more time for the exam. You might realise you're going to be distracted and set aside, extra time essentially and get through that way. You can have an increased intellect or capacity to learn. So you might be someone that can, procrastination is common with ADHD. You might procrastinate, but have the capacity to cram and still succeed. Or you might sort of get put yourself in a situation where you're supported essentially, and your ADHD is actually allowed to flourish. And you might be able to have like either a secretary, a peer, a partner that sort of organises your life to allow you to sort of focus on one or two specific skills.
So it's a really important point, is it? Because I mean, this while we're saying here that it's relatively common, of course, we're not saying everyone needs to be treated either. And so I mean, these are examples of probably more sort of high functioning people that might have sort of mild to moderate or maybe severe but still high functioning. It's remarkable, really, isn't it, that you can do that?
You can certainly hyper-focus on some skills. I had a patient recently. Fortunately, they're not a Northern River patient, so I feel I can sort of briefly touch on them. It was a patient from Victoria. They had a surgeon, and he was a guy that he failed. I think it was one of the years in med school, which is not that common. He then got into a good peer group. They supported him through medicine. He was able to get onto a surgical program, and he's an excellent surgeon. He's got all the supports around him. He has good registrars. He's got a good secretary. His relationships not so good. They struggle, but you can certainly be high functioning.
Yeah, and I think the other take. Oh, sorry. I was going to quickly say the other message I got is that it's not related to IQ at all. This condition, it's ADHD and IQ are separate issues.
No, completely separate. Yeah. You may not function as much as your IQ would have otherwise, but if you get the supports around, you can certainly do really well. Yeah. And look, so there's some of the creative arts, being an entertainer, being a musician, they can actually be benefit from having ADHD.
Yeah. Oh, thank you. So we'll move on to the next slide. So the next two slides are now going to focus on making a diagnosis. So back to you, Hugh. So myth or fact? So I recognise the kids with ADHD, they destroy the consulting room in about 3 minutes. Adults with ADHD are just the same.
So look, that one's a bit of a myth. Hopefully, I hope that doesn't happen to us. Generally, that tendency for hyperactivity tends to diminish towards the end of adolescence. But what you might see in adults is fidgeting. So that's maybe there, and their leg is just jiggle, 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 or they just keep fidgeting with their pen, or they may just keep getting up and down. And the other kind of classic things are they may be late for the appointment. I have some adults who have arrived late, and then they go and help themselves to a cup of tea while, and you think, you're late, you should be coming in here now. And these are some of the clues from the clinical history, and James mentioned procrastination, and that is, I think, such an important problem for people. They leave, the tendency is to leave everything to the last minute, particularly boring stuff. So if you're interested in something, that's fine. And so this is where, say, kids in school can excel in some subjects that they really like, and it also helps if you've got a good teacher. But if there's something that's a bit effortful, a bit boring, really difficult. Kids at school have terrible problems with homework, leaving it to the last minute, not doing it at all. And adults, the same, with getting assignments done. One of the things that is actually really significant that people perhaps don't realize is having problems with regulating emotions. So people with ADHD, not only are they impulsive behaviorally, but they can be impulsive emotionally. So an adult may, say, get really frustrated with their kids and like we all do at times, but actually find this happens a lot. And feel really bad about it. So that and perhaps, say, being in a queue and get really angry, or being more prone to road rage. So emotional dysregulation can be really a problem. In conversation with people, people with ADHD may talk very rapidly. And I'm sure in the past, I've probably confused these people as having bipolar disorder, being manic. And the difference is that it's kind of verbal. They just keep talking, and you think, where are we going? It's like it's over-inclusive, circumstantial. And they can be prone to blurting things out because in that moment, if they don't say it, they worry they forget it. And similarly, they may interrupt and kind of overshare. So somebody may say, look, don't tell Peter this, but it comes out. I was saying before that people with ADHD are frequently late because they have terrible problems with time. So it might be, oh, look, I thought I put the laundry on, do the washing, and I didn't realize it took 20 minutes to get here. I'm sorry, I'm 20 minutes late for my 20-minute appointment. Forgetting, losing, misplacing things all the time. So people with ADHD are prone to constantly misplacing their keys, phone, other items. Managing money is also really common. I have had lots of adults who haven't paid their tax return for 7 years. They're behind on bills. There's a problem, I think, going back to time management of overcommitting. So I saw a lady today who was amazing. She was an entrepreneur, but her day was, she's just frenetic. And in fact, what was really funny, I was 10 minutes late, and was interviewing and went to interview her, and she was in Bunnings. And she could not wait. She had to go into Bunnings, and she was a bit annoyed with me that because she's very busy, she's got things to do. So anyway, we got that interview done. I've mentioned road rage and speeding fines and parking fines. It's really common that people lose their licenses, and it's sometimes more that they just they go through a school zone and they've not noticed that it's a school zone. Sleep, 80% of people with ADHD have problems with sleep, delaying going to bed, difficulty switching off at night. And it is amazing why. Sleep's boring. It's boring going to sleep, boring going to bed, much more interesting being on your phone, staying up all night, watching the latest episode on Netflix. Now, tying into all this, people very commonly have low self-esteem because they compare themselves to their peers. They can see, look, I'm really bright, I'm really capable. Why aren't I achieving like my friends? Why am I not married or whatever? So there's often a sense of underachievement. And interestingly, diagnosing ADHD in adulthood, there's often a sense of grief about what, if only somebody had diagnosed this before, if only I had treatment, how different things would have been. So it really is important to pick up these clues in the history.
It's really interesting, Hugh, and that comment about like you can still concentrate on things you enjoy really just struck me there because when I always sort of think, is it global? Is it happening at home? Is it happening at school? And some parents and the parents might say, it can't possibly be ADHD. This is more in children, because they can sit there and they can do this for hours. So it's really interesting to hear you say that because that, of course, doesn't exclude it if they're doing something.
No, it doesn't, and look, it's really interesting. There's a correlation with people who are entrepreneurs having ADHD, and they're often the people who they get these amazing ideas, and they're the big picture people, and they'll take risks, and sometimes they are incredibly successful. It's really, really, really interesting. Sometimes, of course, things don't go well and they lose a lot of money, but they're probably the people really who change the world, which is pretty cool, really.
Yeah, I wonder if Elon Musk has got ADHD.
I reckon he might. I think
that's another webinar.
He's probably on the autism spectrum too, I think.
Maybe a bit of that too. Yeah, we won't go into psychoanalyzing Elon Musk tonight. So there is another slide about what you might see in your paper in your room. So you mentioned things about fidgeting, foot tapping, poor historian. I think some of these things. I'm sure when you go through that list, people were thinking perhaps of patients they know, maybe even people they know who may have ADHD, just thinking about some of these characteristics. But yeah, it is a bit different. It's definitely not. I was thinking the adult version of someone who destroys your room in 3 minutes, the only person who sort of threatened to do that was actually drug-seeking people who are sort of in a bit of withdrawal and, getting violent. Certainly ADHD people aren't behaving like kids. And yeah, so that's the other point too, is you're saying that hyperactivity tends to wean off as they approach adulthood.
Yeah, look, I think the other thing that James and I haven't mentioned too is that that people may present with ADHD combined time, where they've got this mixture of inattention and some of these symptoms of hyperactivity that are more expressed with this fidgeting and tabbing. There are some people who have mostly inattentive ADHD, and so they may be more dreamy and vague, and and you may be able to think of people like that as well. So they may not be quite as fidgety, but they really might be quite scatty, vague, and anxious, I guess, as well. It's quite common too.
Yeah. Yeah, so you mentioned screening tools, and we've just got a snapshot from a screening tool here, and we'll try and make one of these available through the Nordocs website when we put this up online. But you can certainly just take a screenshot of this and Google it fairly easily. So I did one of these for the first time the other day, Hugh, with someone, and it was basically they were very often with all of them. In fact, there's no doubt this person had severe ADHD. They were like tapping their feet, fidgeting, getting up, getting down, and sort of laughed at me hysterically every time I asked them a question because they were spot on them. It was like, of course I'm like that, and oh my God, that's exactly like me. So I didn't even need to bother look up what the scoring was because they were just very often in every one.
Yeah.
But so that's good that you've referred that to us, because I found that quite helpful to do with the patient, and I guess you can ask them to take it away and do it before the next appointment as well.
The ASRS is actually designed for general practice too, and it was kind of designed by the people in the World Health Organization. It's quite a good and well-validated screening questionnaire, which is good. Yeah.
Yeah. So we'll go to the next slide. So it's common for ADHD to be part of other coexisting psychiatric diagnoses. Is or fact, James?
I think it's me, isn't it? Yeah. Look, yeah. That's a fact. I think at least 50% of people with ADHD have other comorbid mental health conditions. Depression, anxiety, substance use are the three most common. There's also, you've got to also be a little bit careful. I think Hugh touched on it before, particularly given the fact that it's only been sort of mainstream in the last 10 years. A lot of people with ADHD have been misdiagnosed with other things in the past. They've had low self-esteem and they've been diagnosed with depression. They've felt overwhelmed and they've been diagnosed with anxiety. And if you treat these people with stimulants, they get better, and the self-esteem improves. They're not overwhelmed anymore. But I suppose
I was going to ask you, someone's asked about hypomania, because some of the stories that Hugh was sort of describing there sounded like a little bit like a hypomanic sort of presentation. So how do you tease that out?
So I guess on the history, that the ADHD generally starts in between 6 and 12 essentially, so much earlier than bipolar would. So a good collateral history is great. From the parents, ideally. You're not always going to get that from someone with ADHD, though. They mightn't have contact with them, and you might just get their partner. ADHD is also chronic. It's there the whole time, whereas bipolar is more episodic. They're the two main ones. Things like sleep. I mean, both can get less sleep, but someone with ADHD, they're going to feel pretty weary the next morning, whereas a bipolar person, they might only get a few hours and they'll jump out of bed.
Yeah, and so I guess the other thing too that we talked about previously is that I guess if you've had ADHD missed as a child, and you've failed the typical schooling system, and so you haven't fitted into the round peg in the square hole in what society wants you to do, and then you've dropped out of school early, and then there's a whole lot of other obstacles in your way to being a successful adult that can then lead to trauma, drug use, PTSD, associated, drug dependence, with all the other issues around depression and anxiety, and then it all just gets mixed in together.
Yeah, very much so. Yeah.
Yeah. Which is sad. So I think that was one of the take-home messages today. Is it's making me just reconsider a whole lot of my patients with more complex mental health disorders, to make myself ask the question: have I missed ADHD, or has anyone bothered to ask the question, could there be ADHD as part of this presentation? Is, I think, a good take-home message.
It's one of those things. I think borderline personality is similar. If someone's got 5 diagnoses, it could be ADHD. Same with borderline personality disorder. It's like, if someone comes with 6 different, if they've got schizophrenia, depression, anxiety, PTSD, they've probably got borderline personality disorder or ADHD. It can certainly mimic a lot of other conditions and be misdiagnosed.
Misdiagnosed, yeah. So we'll go to the next slide. So just a few other points there.
Yeah. So look, I think the question was, well, which do you treat first? And if it's anxiety, depression, which is very common with ADHD, you're probably going to treat whatever's more severe. If someone's coming with melancholic depression, you treat that first. If they're about the same, personally, I'd treat the ADHD first, because the person's probably been on an SSRI or they've been given a trial of CBT. So look, I'd try the ADHD because there's probably going to be more upscope in the treatment. A few of the exceptions to this would be if someone has bipolar. It's important that if you've got bipolar and ADHD, it's important you have the bipolar very well managed first. any treatment for ADHD risks precipitating a manic or hypomanic episode. The stimulants and atomoxetine, and with a psychotic episode, with psychotic symptoms, in particular something like schizophrenia, it's really hard to diagnose someone with adult ADHD if they've got schizophrenia, unless you get an amazing collateral history. There's a lot of overlap with the symptoms, the cognitive symptoms, the behavioural symptoms, it's a pretty tricky sort of thing to deal with. So you'd want to make sure that the psychosis is well under wraps. You probably wouldn't use stimulants either because they're pro-psychotic. And if someone's got a significant substance use disorder, and for me, significant means if they use ice or if they use cannabis greater than weekly, you'd need to get off the cannabis first, or off the drugs first, and probably not use stimulants as a first-line agent as well.
Yeah, yeah. Look, one of my patients I saw today, who gave me consent to talk about him, has some trauma in his background and a long history of ADHD, and a failed relationship, and impact on his relationships and his job and his self-esteem, and a history of PTSD, and he was using ice. Partly because of his trauma, like some other people who get addicted to medicine, but also partly to sort of self-manage his ADHD. And he's managed to get off the ice, and we've managed to get him onto to long-acting medication. And yeah, it's made such a massive difference to his life. His relationship is stabilised. He can sit down through counselling and do it for an hour. He's going to get back into work this week, it's made a really big difference to him. Yeah, so that's a good news story, that one. So that's great, James. We'll just go on to the next slide now, and want to start now talking about medication, particularly because we want GPs to be confident about co-prescribing. So after starting a patient with ADHD on stimulant medication, they often tell you they feel calmer. Is that a myth or a fact, Hugh?
That's actually a fact, and this often surprises people, that you assume, it's a stimulant, so I'm going to be stimulated. And so when a person responds well to stimulant medication, they report feeling calmer. They often will say things like their mind is quiet, so instead of having lots and lots of thoughts interrupting, that it's actually quieter. It's easier for them to think. It's easier to get started on things, stay on task. Not get distracted. If they're interrupted from the task they're doing, they're able to go back to it and continue with it, and to complete tasks. And so as a consequence of this, it makes an enormous difference. People's short-term memory improves. In conversation, they're less inclined then to blurt things out because they can hold their thought in their head. So people are able to better think before they act. And what I find really interesting is that people will just keep noticing all these changes. And I think that sometimes they can just get overwhelmed with, my goodness, this is just so different, to how they feel. It's funny, this is on a smaller scale, but I remember when I was about 26, I went to an optometrist, and I'd been, going to restaurants and squinting at the board to see the menu. And I remember putting the glasses on and walking out in the street and actually looking down and thinking, my God, I can see the whole, all the signs, everything's clear, I can read them. And I think this is a little bit like what it is with kind of getting this response with ADHD, that it's like a transformation in the way they feel, think, and kind of interact with people. It really, it's a very good, thing for people. When some people do not, have this kind of response, they don't feel calmer, they actually can, some people may actually respond and feel agitated and anxious. And if that happens, it's important to try a different stimulant. And if both fail, that they don't feel calm, then you try a non-stimulant. Yeah,
right. And so that's really helpful. And just quickly going back to the comorbidity, someone has asked if either of you answer this question: is ADHD a risk factor for dementia in the same way as other major psychiatric conditions are for dementia? Anyone know the answer to that, James or Hugh?
I'm not aware of any connection myself.
I don't know either. I do know that mood disorders are connected, and that that's important to treat depression, to treat bipolar illness, because repeated episodes can actually increase risk of dementia. But I'm not sure about ADHD. I don't know.
There you go. There's a good study for us to do. Okay, so we'll go to the next page. So James, starting stimulant medication can be used diagnostically. Sort of already answered this, haven't we?
Yeah, look, to be honest, it probably shouldn't be used diagnostically, but it is at times. If you're not sure, I certainly err on prescribing, and it can be very confirmatory at times. It's great. You almost certainly, it's not that difficult an illness to prescribe, to diagnose, but there's times where you go, oh, I'm not sure, and you try the stimulants, and it's just like they just come back, and they come back with this just, I feel so much different sort of reaction. So it's really nice when that happens.
Yeah, great. And then the next slide is Hugh. Can GPs prescribe stimulant medication?
Look, this is true. They can. What is very irritating is that in every state and territory in Australia, the rules are different. So in New South Wales, the GPs can prescribe medication once the stimulants have been prescribed by a psychiatrist or a paediatrician, maybe not a paediatrician, by a neurologist, and then the prescribing can be handed over to them. And I believe, James can verify this, I believe in Queensland, GPs are able to initiate patients on stimulant medication.
I think, look, my understanding is the same here. The GPs can prescribe after seeing a psychiatrist, and then they suggest the patient see a psychiatrist every year, but it's not essential.
Yeah, right. Yep. So we're going to talk about how to do that in a little bit more detail in just a second. Or there's just another question before we go into medication. Are there any known causes for ADHD? I suspect that might be risk factors, causes kind of thing.
Yeah. So, well, what we know is that if you compare, say, mood disorders, to major depression, we would typically say 50% is due to environment, 50% is due to genetics. So in ADHD, 80% is due to genetics, 20% to environment. And a lot of the environmental factors are sort of the same kind of factors that you would ascribe to probably all sorts of conditions. So if your mother was a smoker, if your mother drank alcohol, if you had, exposure, if you had a mother who had exposure to the flu. So all those environmental insults during pregnancy may increase risk. James, can you think of any other?
I think childhood trauma is a risk factor in a way that it's almost like the brain's been just hasn't been allowed to grow properly, essentially.
Yeah. Yeah, I know that in children who are at risk or have been diagnosed with FASD, then ADHD can be part of the spectrum of behavioural illnesses in FASD. So I think, alcohol history and pregnancy is really important to ask about. So look, that's great. So let's go into this table. So we're going to briefly have a look at this table so GPs can get to know the sort of medications you're using. Obviously, we're not starting it, so we'll be taking over prescribing, and I'm going to explain how to do that in a minute. But just briefly, we'll start with you, Hugh. Just briefly sort of walk us through this table
Sure.
About what's available, what's on the menu, the stimulant menu that psychiatrists can use.
The stimulant menu that we have, so the two main agents are dexamphetamine and methylphenidate. And the dexamphetamine is the standard 5 milligram tablet, and the long-acting version of that is lisdexamphetamine or Vyvanse. What is interesting is that there isn't a good correlation between doses of dexamphetamine and Vyvanse. So if somebody is, say, taking 5 milligrams of dexamphetamine 3 times a day, you can't really work out, well, what will the equivalent be in Vyvanse? The reason for that is that Vyvanse is a prodrug, and so LIS is lysine, and as a molecule, it's very rapidly and well absorbed in the gut, And compared to dexamphetamine, which has a much more variable absorption, and also it undergoes first pass metabolism. So there's a much greater variation, whereas that doesn't occur with lisdexamphetamine. Once lisdexamphetamine is absorbed into the bloodstream, it doesn't undergo much first pass metabolism in the liver. And in the bloodstream, red cells on enzymes on red cells cleave the lysine off the dexamphetamine and release. So you get this incredibly steady release of dexamphetamine. Methylphenidate, so there's the immediate release 10 milligram tablet. There are two long-acting forms. There's Ritalin LA, and the capsules have granules in them, half released straight away, the other half released 4 hours later. It is much easier to correlate dosage of Ritalin with long-acting. So if somebody is taking 1 10 milligram Ritalin in the morning, 1 10 milligram Ritalin at lunch, that would be the same as taking a Ritalin LA 20. To compare that to Concerta, Concerta is a little bit more confusing. Roughly, the 36 milligram tablet of Concerta would be equivalent to 10 milligrams 3 times a day of Ritalin. The 18 milligram would be like taking half a tablet 3 times a day. And as you can see, that's a tiny dose. And the 54 milligram tablet is like 1.5 tablets 3 times a day. So that is kind of, if you have somebody on short acting, it's easy then to transfer them to long acting. In general, it's better to have people on long acting, children, adolescents, and adults, because it's just a lot easier. For taking any medication, once a day is hard enough. Twice a day is really annoying. 3 times is a nightmare. So as much as possible, if I'm seeing an adult, I will generally start them on a long-acting medication. As of February this year, lisdexamphetamine was made available for adults who had not had a diagnosis of ADHD in childhood, which is enormous. So it means that it's much more accessible to people. It was very expensive. It was something like $120. Now it's not. The other medications listed there, atomoxetine, Strattera, that's been around for a long time. And if people can't tolerate stimulant medication, that would be a second-line treatment, or if they are using substances. Guanfacine is kind of newer, or Intuitive is the brand name, and it unfortunately currently the TGA has kind of recommended it really for children and adolescents. This is because there haven't been studies in adults, but clinically I've been using it quite a bit in adults. If an adult has been diagnosed with ADHD, then they can get that on authority. If they haven't, then it's expensive. It's $113 a month. But adding guanfacine can sometimes really make a difference. So sometimes people may get a partial response, or they may feel a bit anxious on stimulants. The guanfacine, being an old blood pressure tablet, can slow heart rate down, can lower blood pressure a bit. People find that it really improves sleep. They feel less anxious. And they may have better mental clarity. So it's quite a nice add-on treatment.
Yeah. And do you have a favourite one you start with?
Look, I do in adults, particularly those who have not been diagnosed as children. I will generally start with Vyvanse, only because it's more cost effective. So it's this ridiculous situation at the moment where Concerta and Ritalin LA are still not available on authority for adults. However, if somebody tried lisdexamphetamine and it made them anxious or it didn't work well, I would certainly switch to a long-acting formulation. Occasionally, some adults A, can't afford to have long-acting, or B, they just prefer it. They prefer being able to take it when they want to. But most adults, I would say 80 to 90% of people will do better on long-acting medication.
And what about you, James? I think you Jim, what do you have a way of going about this, or?
Yeah, so my eventual outcome's the same. I want to get them on a long-acting medication. It's better once a day. It's a smoother treatment. I generally start them on a short-acting though, partly because I can dial the dose up and down a lot quicker. And it also, some patients are a bit apprehensive. They said, I don't want to take a stimulant. And say, look, this will be out of your system in 4 hours. So if you don't like it, or you can stop taking it essentially. So I start on a short acting, generally try both, the Ritalin and the Dex, see which one they like, and then transfer them on a long acting version of that.
So the cost is obviously an issue. So just so this is more of an issue for you guys who are starting it. But just briefly, you're saying Vyvanse is now on the PBS, even if you didn't have a diagnosis as a child. But you're saying Concerta and Ritalin LA are not on the PBS. Is that right?
Mm.
Wow.
Right. For adults who are not diagnosed between the ages of 6 and 18. That's right. So it's an absurd situation where
dexamphetamine is on the PBS.
So dexamphetamine and methylphenidate are so old now; they're both about 50 years old. If you go to a competitive pharmacy like, say, Chemist Warehouse, you can get on a private script 100 dexamphetamine tablets for $11. Similarly, 100 methylphenidate for $11. So you don't even need to bother putting it on authority, really.
Right.
Yep. But Concerta, that may cost more like $55, $60 for a month's supply. Yeah.
Oh, cheaper than THC oil still.
That's
what I tell patients.
Very true.
That's interesting. So let's go on to the next slide. So this is how you do it. So basically, you refer the patient to the psychiatrist. The psychiatrist has made the diagnosis and has stabilised the patient on the medication that the patient and the psychiatrist are happy with. And then at that stage, the psychiatrist can then write to you, or you can ask them, you'd like to do it, to take over prescribing. And you just go to this website. You can just Google New South Wales Health Stimulant prescribing, and it'll take you there. And then you download the application and basically fill out the form. So the bit on the form that you need to know about, which is in the next slide. Go to the next slide, thanks. Is here. So as you can see there, just look at the bottom of the slide. If you're not a specialist, then you just tick the right box. So the treating specialist requested that I continue prescribing for this patient, and then to be reviewed annually. Now I rang the New South Wales number here and spoke to the pharmacy, and they've accepted that comment, to be reviewed annually, is very badly worded. So what they mean is that you as a GP have to keep asking every year to keep being the prescriber. You don't have to send the patient back to the psychiatrist every year to have a review, which was what I thought the case was. So you can tick that box, and then you send it off to authority, and then they get back to you in a week, and then they give you a yes or a no, and I've never been knocked back yet. If the person's using drugs, it's a bit more tricky, but we won't go there for this evening. But the bottom line is, let the psychiatrist do it if they're still dabbling in illegal substances. But for a straightforward case, like most of them are going to be, then you get the letter from Hugh or James, you send it off with the application, tick the right boxes, and they'll within a week they'll get back to you, and then they'll give you an authority number in the letter that they send back to you. Now that authority number has to be written on the script, along with the authority number from PBS when you ring up for the medication, so long as it's a PBS prescribed stimulant, and of course it may just be a private one, in which case you wouldn't need to do that second part. Now, if there's a break in treatment for a prolonged period, then they prefer the psychiatrist to check, and that break hasn't been stipulated. The pharmacist I spoke to didn't give me a specific time frame, but GPs can, without going back to the psychiatrist, lower the dose of the medication, but they can't increase the dose of the medication, and they can't change the type of stimulant. So as long as they're stable and it's the same tablet, and you just want to keep doing it year after year, so long as you apply every 12 months for a new authority and put that authority number on the script, then there's no reason why you cannot be their prescriber for as long as you or the patient requests. So I guess that just goes to a quick question before we wrap up to the panel about if there's a break in treatment, like if someone stopped it for 3 months, do you just go back on the dose that you were on before, or do you have any sort of general advice? Does it really depend on what sort of medication they were using? Hugh, I might start with you. Do you have any advice about that?
Look, I would just get the person to go back on the dose that was effective, really, unless they felt, anxious about it. It's a kind of bit like, you know, your glasses you haven't worn for, you know, a few months, you just put them back on again. And that's, you know, because the person has actually established that dose and it generally doesn't change. That would be, yeah, my advice. And I think too that if, say, the GP was prescribing and the person had, you know, not taken medication for 3 to 6 months, I think that's probably okay, really. If they had stopped for, you know, more than 6 to 12 months, then fair enough, time to, you know, go back and be reviewed. But I think that 3 to 6 months is very easy for people to be disorganized, to try it. Yes, I was going to make an appointment, I ran out, but, you know, it's, yeah. So I think that's not too bad, that period of time.
And James, you have anything to add to that?
Oh, look, it'd probably only take them a few days to get used to the dose again. The first couple of days, they might be a little bit more agitated, but yeah, I'd start on the same dose as well.
Great, fantastic. So, and then that next slide there is just to make you aware there is another document you can download for people under the age of 18 if you have a letter from a specialist that they aren't able to prescribe at that time. Then you can do it on a short-term basis. So we'll go to the next slide because we have unfortunately run out of time. So just in summary, really we really want to decrease the stigma. Hopefully we've done that tonight, and to make you realise this is an undertreated and underdiagnosed illness. And just to remember that it's often a family affair. So when the parent comes in and says, my kid's got ADHD, definitely listen to that story. And think about what other comorbidities might be along with ADHD, or conversely, like I said, patients who have got lots of complex mental health issues, ask yourself, has ADHD been missed? Remember, there are screening questionnaires you can use to help yourself in regards to the diagnosis, and that we really encourage you to be co-prescribers because that frees up Hugh and James to see more of our patients to start medication, and it's also really good for patients that the GP is doing this sort of thing. So one last question. What's the oldest person you have ever diagnosed with ADHD?
Mine was 73.
Wow. Wow. And you started medication?
Yeah, very cautiously. I don't normally get ECGs, but I got an ECG for this one, did bloods and all organic.
Yeah.
I did an organic workup, which is not usual.
And how did they go?
Good.
Great, fantastic.
Yep.
And what about you, Hugh?
Look, I think I've started people with treatment in their 70s, but it's interesting because I've been going for a while. I certainly have a few people now in their late 70s and early 80s who are on stimulant medication because I've been treating them for more than 10 years. So
time to turf them back to the GP. Yeah, so look, that's all we've got time for ADHD tonight. We've got a few more things to come for the last 2 minutes, but I'd really like to thank both of you for your time. If you need to contact either Hugh or James, that's where you'll find them. And I know they've both told me they're happy to, speak to GPs on the phone when they're doing co-prescribing or you're referring patients, like all our friendly specialists in the area. So thank you guys so much for coming along tonight. I really appreciate it, and we'll see you around the area.
Yeah,
thanks very much, Peter. Cheers. Thanks.
So we'll just go to the last. Oh, we'll go to mystery guest. Okay, so a friend of Nordoc's is coming. Oh, Hilton Copy. Hello, my friend. How are you?
Hey, Pete. Hey, everyone.
Hi. So Hilton's been doing some things in his spare time, and he's going to quickly talk to you about a really exciting podcast that he's helped put together.
Yeah, thanks, Pete. I've been working with Dementia Training Australia for a few years now, trying to develop engaging and interesting educational materials about dementia. And one of the really exciting projects that we've commenced has been a series of podcasts. It's called Dementia in Practice. On the screen, you can see the 6 episodes that are available in the first series. There's another series that's in production at the moment. The episodes are about 30 minutes long. They're very conversational, interview style. podcast episodes. We're trying to reach people's hearts as well as their heads, and hope that you'll enjoy it. You can get them, like they say, wherever you find your podcasts. So on Apple Podcasts or Google, and I'll put in the chat box a direct link to the DTA, Dementia Training Australia GP education page, and the podcasts are all available there as well. And I'm interested in any feedback. If you do have a listen, most of you would know how to get in touch with me. So I hope that you enjoy it. Thanks,
That's
Pete.
great, Hilton. I've already downloaded them and started listening to them on my way to work. That's great. They're really enjoyable. So thanks for that message. And please don't go. We just need your help a little bit longer. So we have another webinar coming up in another month with Dr. Abood, and that's going to be on eyes in general practice, ophthalmic conditions in general practice. Just a reminder about Nordocs, and that we have a webinar. We have a website page. You can access the old webinars on there. This one will be online and available shortly in about a week or so. And after you finish the webinar, we're just going to flick you a quick questions to review the webinar. And if you complete that, then we can give you a certificate for your CPD points, and you can register for next month. And we'll see you next month. But thank you so much, everyone, for coming along, and I really appreciate all your questions, and we'll see you next time.